Thank you, Chairman, ladies and gentlemen. Just I talk the cancer and the heart failure. And this area is ignored in the cardiologists because oncologist, cardiologist, and the interrelationship is not so tight. So now the number of the cancer patients treated with chemotherapy is increasing. And a new drug with possible cardiotoxic effect is the challenge to develop. And survival time after chemotherapy is increasing these days. And the physician is a more aggressive chemotherapy to save the life of the patients. So the higher number of the patient recovering from cancer, that means the cancer survival is increased. And mechanism of the therapy-induced damage is classified in three types. One is direct effect of the heart, caused left ventricular dysfunction, arrhythmia, and ischemia. And the second is the effects on the blood vessel, particularly endothelial cells, cause hypertension, ischemia, thromboembolism, and renal dysfunction, proteinuria, cause proteinuria in the kidney. And the last effect on the coagulation system is caused the thromboembolism, increase the incidence of the DVT or PE, or even the stroke in patients with atrial fibrillation. So this slide shows the brief list of the cardiovascular complications of the cancer, drugs, and cardiac adverse events. Anthracycline and alkylating agents and metabolites and microtubules agent and biological agents recently observed. And you can see that doxorubicin, this is the adriamycin, is the typical drug for the induced congestive heart failure, LV dysfunction. And here the congestive heart failure, and this is also congestive heart failure. And this is Herceptin, the congestive heart failure and LV dysfunction, and here. So ischemia or the LV dysfunction is a common cardiac adverse effects of these anti-cancer drug. And this is chemotherapy associated with ischemia. And this list shows that antimetabolites, fluorouracil, as called 5-FU, is very popular indicated for the gastric cancer. Its incidence of the ischemia is reported from 1 to 68%. It depends on the report. And antimicrotubule agents, Taxol or Taxotere, is less than 5%. And monoclonal antibody-based tyrosine kinase inhibitors, so-called Avastin, for the indicated for the colon cancer, is less than 1.5%. And recent small molecular tyrosine inhibitors, Taroseva or Nexavar or Sutent, is also the ischemia-induced anti-cancer drug. Let me show you the one case, 76 years male, and he complained of chest pain, but his history in 2008, renal cell carcinoma was found, and he had a left radical nephrectomy was surgically obtained, and 2 years later, he found a recurrent lesion in the lung. So the physician treated the patient with Sutent. And 5 months treatment after, the patient complained of chest pain. And this patient had a dextrocardia. And this slide showed that the CT scan showed malignancy space occupying a mass in his left kidney. And 2 years later, chest scan showed the recurrence in the lung here. So this patient treated with Sutent, and 3 months later, unfortunately, the tumor is markedly reduced. However, 2 months later, this patient complained of chest pain. And this is the schematic graph of the sunitinib, and ejection fraction before the treatment is 63%, something like that. And during this course, a little bit decreased ejection fractions. And here, he complained of chest pain. However, our coronary angiogram showed that normal coronary angiogram. So this ECG showed that during chest pain, definitely ST segment depressions. And whereas the ECG on admission is not normal, but it's a non-specific STT segment change. So this ischemia, the cause of the ischemia is not known. However, the microvascular abnormality may be involved in this patient. So we performed the radionuclide image, and in the posterior wall and apex, you can see the reduction of the flow, and ejection fraction at that time 48%. And MYBG scintigrams also show that the inferior wall and the posterior wall is sympathetic uptake reduced, and heart and mediastinum ratio 2.36 is a little bit decreased, and washout rate is 30% is increase. That means just like dilated cardiomyopathy, the sympathetic alternation of normality was observed. So in this patient, we treated with nitrates, and after the treatment, they recovered in chest pain. And this slide shows that chemotherapy associated with left ventricular dysfunctions, and anthracycline and alkylating agent, antimicrotubule agents, is the, as you know, the adriamycin is the most popular anthracycline, and incidence of LV ventricular dysfunction up to 26%. And the alkylating agent, cyclophosphamide, is the incidence of the LV dysfunction up to 28%. So anthracycline is a most high-risk drug for the LV dysfunction and heart failure. This is anti-tumoral antibiotics, and indication is very broad: malignant lymphoma, lung cancer, gastrointestinal cancer, breast cancer, bladder cancer, and osteosarcoma. However, the adverse effect of this anthracycline neurosuppressions, nausea, hair loss, and cardiotoxicity. And the most remarkable characteristic of this anthracycline, the adverse effect, is dose dependent. So cumulative dose is 450 milligram per square meters is a critical dose. So if you give more, it is very high risk for the LV dysfunction is induced. And risk factors: elderly, more than 70 years, female, combination therapy, mediastinal radiation, previous cardiovascular disease, including hypertension, the coronary heart disease. These are the risk factors to induce LV dysfunctions. And pathophysiology mechanism is based on the oxidative stress induced by anthracycline. So the mitochondrial dysfunction, lipid peroxidation, and oxidative stress suppress DNA, RNA, and protein synthesis. They reduce protein expression together with degradation of myofilament, disruption of sarcomere proteins, and most important, the free radical formation, and oxidative stress and damage. This is cause irreversible change of the myocyte. So anthracycline cardiomyopathy is classified two types. One is short-term cardiotoxic effect. It occurs within 1 week or up to 3 months, as observed the pericarditis, myocarditis, or acute cardiac dysfunction. And ECG change observed 20% or 30%, non-specific SCT change, flat T wave, decreased QRS amplitude, QT prolongation, sinus tachycardia, arrhythmia. And subacute cardiac dysfunction causes tachycardia, general fatigue, and dyspnea, causing a congestive heart failure. Then we have to care that this anthracycline are sometimes often used the combination with the other cancer drugs. Adjuvant anthracycline is getting worse than no adjuvant chemotherapy. This is a breast cancer woman. So we call this chronic progressive cardiotoxicity. And chronic progressive cardiotoxicity is classified two types. Early onset, within 1 year. Heart failure after the administration of anthracycline causes chronic dilated cardiomyopathy like pathophysiology, and it's occurred within 1 year. And surprisingly, delayed onset, some patients several years or even 10 years after the completion of the treatment, stress, aging, or a viral infection may cause a decompensated heart failure. So this slide shows the survival of the various cardiomyopathy, idiopathic cardiomyopathy, ischemic cardiomyopathy. This is anthracycline cardiomyopathy, is the worst cardiomyopathy in terms of the prognosis. And this shows that the dose-dependent occurrence of a heart failure on the cardiac events. So look at this, 40 milligram per squares is a critical point of the cumulative dose of the anthracycline. And after that, it's an increase in dose dependently. And cardiac event, as observed, and a decrease in the ejection fraction, is a little bit earlier start. So we have to check the ejection fraction to predict the heart failure in patient of the cancer. Another type of the anti-cancer drug is monoclonal antibody-based tyrosine kinase inhibitors. This is a trastuzumab, is a Herceptin. And incidence of LV dysfunction is up 28%. It is not so small. And Avastin is more or less. And small molecule tyrosine inhibitors, Glivec or Typark or Sutin, is also in some extent the incidence of LV dysfunction we have to care. And this slide shows the intracellular signal transduction in the breast cancer cell, and effect of the Herceptin, in several pathways, Herceptin block the growing of the breast cancer cell. The one is activation of antibody-dependent cellular cytotoxicity, ADCC. It's a moderation of a natural killer cell or the immunomodulation system. So the Herceptin inhibit the growing of the cell. And also the inhibition of cell proliferation. This is the EGFR receptors. And the breast cancer cell, the ERB B3 type is expressed. And tyrosine kinase here. So they inhibit the Herceptin, the intracellular pathway to cell growth through ARC activation is inhibited. And also the PI3 kinase activation, AKT. This AKT blocked the pathway of the apoptosis of the cell. So inhibition of the RB3 is the increase the pathway of the apoptosis. So this drug is very effective to apoptotic death of the breast cancer. And also the inhibition of angiogenesis and the prevention of formation of P95 or P85 is also the helpful to kill the cell. What's happened in the cardiomyocyte? Here is a cardiomyocyte. The cardiomyocyte is a very similar transduction because EGFR here, and the subtype is different. This is the ERB-B3, but in a normal cardiomyocyte, ERB-B2 and B4 type. However, the intracellular signaling pathway is very similar, and if we give the Herceptin here, then in normal cardiomyocyte, this pathway, ARC pathway, is inhibited. And also the FAC pathway is contribute to the contractility. So if we blocked here, then contractility is depressed. And also the PI3 kinase pathway activated AKT blocked the apoptotic pathway. So if we give the Herceptin, and this pathway, that means on some cell, the apoptotic cell death in normal cardiomyocyte. So this mechanism is a humanized monoclonal antibody binds the extracellular domain of HER2. This is another name is HER2, and homo and heterodimers to inhibit surviving signals. ADCC is induced against HER2 expression cells, mitochondrial dysfunction via BCL's XL downregulation, promoting apoptosis and inhibiting AMPK, causing ATP depression. Adverse cardiac effect has been reported, particularly when combined with the other chemotherapies, such as anthracycline. So the combination with the anthracycline and Herceptin is a very complex pathway modulation in the cells. And this is the 46-year female breast cancer. And before the treatment, she showed the ejection fraction, the 56%. And we started adriamycin and Herceptin here. And 1 year later, the ejection fraction decreased 13%. She complained heart failure. BNP is increased. So she consulted to the cardiology, and we started the HAMP and the furosemide, and also the ARB, spironolactone, and the digoxin. Unfortunately, ejection fraction recovered almost to normal, and we can restart to the Herceptin. So we continue this ARB and spironolactone, then the depressed of the ejection fraction is small. It does not cause the heart failure. And this is a Herceptin treatment, ejection fractions in our institute, and the mean value is 69%, and 6 months after, ejection fraction decreased to the 65% in the average. However, in some patients, the ejection fraction reduction is remarkable to 40%. So the grade 2 deterioration is observed about 30% of the patients, and grade 3 only 6%. And we have to know that type 1 and type 2 are myocardial damage. Type 1 is myocardial damage represented with anthracycline cardiomyopathy. This is irreversible myocardial damage. And type 2 is a myocardial dysfunction, and this is the Herceptin-induced cardiomyopathy. Is mostly reversible myocardial injury, but not all. And 10% of the patients is a delayed recovery after the stop of the Herceptin. So we have to consider the two pathway of the pathophysiology of the heart failure. As adrenomycin, hypoxia, oxidative stress, RAS or adrenergic signaling enhancements, it's caused cell death. And one is early onset cardiomyopathy and late onset cardiomyopathy. And Herceptin, the trastuzumab, is a tyrosine kinase inhibitors, decrease nitric oxide and moderate the growth hormone pathway, and through AKT GP130's increase, this is the homeostatic mechanism modulations. So they largely recovered and reversible. So as a clinical practice, we have to the collaboration of the oncologist and the cardiologist. And early diagnosis and cardiotoxicity is very important. And at present, ejection fraction by echo is the most useful. And biomarkers, BNP and troponin is also useful. However, it is not perfect. So Herceptin's cardiomyopathy, some patients don't change the BNP even immediately before the heart failure. So the conclusion of my talk is the most anti-cancer drugs have cardiotoxicity and thus frequent monitoring of the symptoms. If possible, every 3 months is necessary, and cardiac function and ECG change is necessary during chemotherapy. Reversibility of myocardial damage, cardiac dysfunction depend on the biological action of the drug. Anthracycline may cause chronic progressive cardiotoxicity even more than 10 years after dose. To minimize the cardiac damage during the chemotherapy, early contact with the cardiologist is recommended for early detection and early treatment of cardiotoxicity induced by anti-cancer drugs. Thank you very much for your attention.
Thank you very much, Professor Hori from Japan, for this very comprehensive and excellent presentation. Due to pressure of time, I've been asked by the conference authorities to allow 2 questions, and then we'll move to the last speaker. So if you have a question, would you please? Yes, Salah.
Thank you very much indeed. This is a very important area. My question is, if you have heart failure and cancer, you have cachexia, you have some immunological, anabolic, catabolic mechanisms acting. Has these patients, people have looked at TNFs and etc. or inflammatory markers?
Yes, it's a very important question. But in Japan, in our clinical practice, the cachexia, the cancer patient is a little bit end stage. And usually these chemotherapy started without cachexia looks normal, condition of the heart and the condition of the nutrition is rather normal. So we did not measure the TNF-alpha or some cytokines, but if we, as you pointed out, if we give these anti-cancer drugs in the end-stage heart failure, then the cachexia or pro-inflammatory cytokines modulation, maybe we have to consider it. So your point is very important in the end-stage heart failure.
One last question, please. Dr. Asadullah.
What are the factors of predictive factors of reversibility? Who will reverse? We have any
reversibility?
Yes.
Yes. The mechanism of the cell death is a little bit different. And anthracycline drug is kills the cells. That means irreversible. And apoptosis, maybe due to the mainly oxidative stress, is very important. However, the tyrosine kinase inhibitors is blocked the survival intracellular pathway during the treatment. So if we stop the treatment, so these intracellular pathway mostly recovered, largely recovered. However, some side is apoptotic death, cell death. So 10%, as I said, is very delayed recovered. And so I believe that it is not completely recovered. Ejection fraction looks normal, but in the pathophysiology of the heart is not completely recovered. So we have to consider the two pathways to induce the cell toxicity.